Hello, everyone. Thank you all for joining today's program on navigating sleep with peripheral neuropathy. My name is Lindsay Colbert. I am the Executive Director of the Foundation for Peripheral Neuropathy. I will be moderating today's session, and I thank you again for trusting us with educating you on this very important topic. Before we begin, just a few minor logistical matters to address on this slide. Primarily, I wanted to let everyone know that yes, we are recording this session and it will be uploaded to our website for future viewing. And for those who are attending this program live, we will be allowing for Q&A at the end of the presentation. Please keep your questions on topic and do not ask any personal medical questions, as we'll only be able to answer those that are pertinent to this presentation and are general in nature. And with that, I'm pleased to introduce today's expert, Dr. Brandon Peters. Dr. Peters is a double board certified neurologist and sleep medicine specialist at Virginia Mason Franciscan Health in Seattle. A recognized leader in sleep medicine, Dr. Peters combines expertise in medicine and technology to advance the field. He is the author of The Sleep Apnea Hypothesis and Sleep Through Insomnia, and creator of Insomnia Solved, an online cognitive behavioral therapy for insomnia program. Dr. Peters has written over 1,000 articles on sleep, and his research covers diverse topics, including the sleep habits of university students, circadian rhythm disorders in the blind, abnormal sleep behaviors, and ethical considerations in sleep medicine. He lectures widely, advises sleep-related industries, and serves as a trusted media expert. We are beyond lucky to have you here with us today, Dr. Peters. Thank you again, and I'm excited to now pass the virtual mic over to you for your presentation.
I appreciate that very kind introduction, and I'm happy to be with you all. Thanks for joining today as we talk about the relationship between sleep and peripheral neuropathy and more widely pain. I think you'll find this to be an interesting conversation, and I look forward to the questions that come up. I will address those towards the end. As noted here, we will also be diving into a related topic. Many people with peripheral neuropathy experience restless leg syndrome, or RLS. We will talk about that at length. There's an associated condition called periodic limb movements of sleep that may be important for people to identify as well. We're also going to spend a good bit of time talking about treatments and medications that may help to relieve pain, restless leg syndrome, and generally improve sleep. So first, I want to go just over some background. Most folks who are attending this lecture are familiar with peripheral neuropathy and know it better than most, but I just want to make sure we're all speaking about the same thing here. So with peripheral neuropathy, there often is associated pain that fluctuates but worsens at night. There are lots of ways people choose to describe these pains and symptoms. Some would say that it's an aching pain or burning pain, and other descriptors include cold, electrical, itchiness, sharpness. It can be shooting, stabbing. There could be tingling associated with this as well. And it's often linked with an overlapping symptom, which is numbness, a loss of sensation. And neuropathy, peripheral neuropathy, can contribute to difficulties with balance, coordination, and movement. Importantly, there are other nerves within the body that become affected, and these nerves may affect some of the automated functions of the body, including regulation of blood pressure, the heart rate, as well as the digestive system, sexual function, bladder function, and regulation of temperature and sweating as well. And so these systems also become impacted in the context of neuropathy. Many here are probably wondering, why does pain get worse at night? Why would someone with peripheral neuropathy have worsening of pain at night? There's probably multiple factors that are at play here. First, I want to point out that we don't fully understand this. It is something that we are still learning about, investigating, researching, and I don't have all the answers, unfortunately, but I will kind of share with you what we know to this point. There is something called the gate control theory of pain. And this is something within the brain. There is a relay center between our bodies and the cortex, the surface of the brain. And ideally, this relay would be turned off at night so that we would not be aware of pains within our body, not be aware of sensations within our body, so that we can sleep more deeply, sleep more soundly, have an improved quality to our sleep, and wake up feeling more refreshed. Now, the gatekeeper here within the brain allows pain signals to travel along the nervous system from our peripheral nerves, the central nervous system, our spinal cord, through the brainstem, and then that's where within the brain it is stopped. So these signals are stopped, and that's through an area of the brain called the thalamus that would primarily direct these signals. If these gates are open, the signals will reach the cortex of the brain, and we become aware of pain. If that gate, the thalamus, is closed and associated structures within the brain are closing that gate, we would not be aware of pain. And there are certain recognized regulators of the opening and closing of this gate. Activity generally will close the gates, so that if we are moving, then we become less aware of pain or discomfort. Physical sensations, and specifically pressure, massage, gentle heat, may also close the gate. And importantly, stress, anxiety, especially when it's untreated, will open the gate. And so again, we become more aware of pain within our body when we're experiencing stress or anxiety. So these are some of the variables that may impact how much pain we are aware of at night and during sleep. Importantly, cold also worsens neuropathic pain, and of course, it's cooler overnight. And there's also a circadian rhythm to a pain perception. So circadian is from a Latin word that means about a day. Many patterns in our body, including hormone release, body temperature, our patterns of sleep and wake, follow a circadian pattern. And in particular, production of cortisol that can suppress pain is increased during daytime, during wakefulness, and decreased or lessened overnight with sleep. Cortisol levels will often come up overnight in the context of other sleep disorders, which we'll talk briefly about, including sleep apnea. And it also generally would rise kind of towards morning as part of kind of the waking pattern. But as a general rule, cortisol is lower overnight, and because it suppresses pain, that lack of cortisol can contribute to more discomfort at night. One other important variable is that when we are lying in bed at night attempting to sleep, perhaps experiencing pain, there is not as much to distract us. So we would not be focusing on other things within our environment. We may not be interacting with other people. We may not be doing other things. And that lack of attention directed outward, or that lack of what is really a cognitive distraction, may allow us to be more attuned to the pain that we're experiencing, and may make us more aware of that, and it can certainly cycle in a way that can worsen the pain. I just also want to briefly talk about sleep and what sleep ideally is. We'll talk also about the normal patterns of sleep and how sleep changes throughout the lifespan. But sleep, as defined, is a transient and reversible loss of consciousness, a loss of awareness to the external environment. And obviously it's very important for growth and restoration of the body and its tissues, also important for memory processing, normal learning, and even creative thinking. There are patterns of sleep that we can identify that include both non-REM sleep, which includes multiple stages, and I'll point those out here in a moment, and REM sleep. REM sleep is rapid eye movement sleep. That's when we have very vivid dreaming. The muscles of the body are paralyzed so that we don't act our dreams out. And it occurs at a 90-minute to 2-hour cycle through the night. Those REM periods get longer towards morning, and so most of the last third of our night is REM sleep, and we may wake out of REM at morning. Now, I wanted to talk a little bit more about slow wave sleep. So within non-REM sleep, there's stage 1, 2, and 3. Stage 3 is our deepest stage of sleep. It's sometimes called slow wave sleep or N3 sleep. It occurs mostly in the first third of the night. It does decline as we get older, so we spend less time in stage 3 sleep as we get older. And it's very important for growth, especially in children and adolescents as they're still growing. But as an adult, it's important for repair of tissues, for building of muscle. and I think would also alleviate pain in those experiencing pain. So stage 3 sleep or deep sleep is very important to experience, to have these benefits to our physical body. This shows a pattern of sleep. This is called a hypnogram. Shows the pattern of sleep through a typical night, and it's honestly a bit idealized. Again, these 90-minute to 2-hour cycles, we start off awake, we drop into light sleep, stage 1, which makes up typically less than 5% of the night. We will go into deeper stage 2 sleep, and that's when the thalamus is starting to be active and muting our awareness of our body. Stage 2 makes up about half of the sleep typically. And then our deepest sleep, our slow wave sleep, or stage 3 sleep, again, mostly in the first third of the night. And it is our very deep sleep when we release the growth hormone and have very slow waves active within the brain. And that's often when we're doing a cleansing process within the brain, something called the lymphatic system, kind of flushing out the brain tissues and cleansing away metabolites that would accrue normally during wakefulness. About every, again, 90 minutes to 2 hours, we're dropping into the REM sleep. That's shown as these red bars. And again, those REM periods get longer towards morning. So most of the last third of our sleep is REM sleep. And we often wake out of REM at the end of the night. I like to point out that at these cycles, 2 hours roughly, it is normal to wake. We will typically wake, might roll over, adjust the covers, respond to something in the environment. And typically people go back to sleep very quickly. If the awakening is under 5 minutes, there's often no memory of the awakening. Longer awakenings people might be aware of and may have secondary insomnia if they have trouble getting back to sleep. If they wake up in pain, it might be hard for them to settle and get back to sleep. This shows some population-based data about these different stages of sleep, and it is meant to demonstrate a few things. So this is from age 5 out through age 85, total sleep time in minutes on the left side there. And it shows the different stages of sleep. There are a few things listed here that are actually wakefulness. So sleep latency is how long it takes to fall asleep at the beginning of the night. In green, we have wakefulness after sleep onset. So if you wake in the night and you have trouble getting back to sleep, that's called WASO. We see the REM sleep, again, that's typically 20 to 25% of our sleep. Stage 3, you can see that tapering off, falling off in our late teens, early 20s, and falling even further as we age. Stage 2, again, typically makes up about half of our sleep. And then stage 1, that lighter stage of sleep, starts to creep up a little bit beyond age 55, but typically is a minority of sleep, 5% or less of sleep typically. So I like to point out that our total sleep time on average declines as we get older. So we need or are able to get less sleep as we age. The slow wave sleep, again, fades out early in our lives. So again, by the early 20s, we're getting less slow wave sleep, less deep sleep than we did. Again, partly because that's when we release growth hormone. And once you've concluded growing, perhaps we don't need as much of that stage of sleep. But there's a normal dynamic process of sleep changing throughout our lifespan. We will not sleep as well as we did as a child, and often we need to make other changes or adjustments to be able to optimize our sleep as we get older. And that can involve changing our sleep habits, treating associated conditions that might come on as we get older, including sleep apnea or restless legs, and addressing other needs to optimize the sleep and rest that we get. So a little bit more about the sleep and the perception of pain. So pain obviously can make it difficult to fall asleep initially at the beginning of the night. That's that sleep onset latency, but also can make it challenging to get back to sleep. If you wake up in pain, you may have trouble falling back to sleep, and both of those contribute to insomnia. Insomnia, by definition, is wakefulness of more than 20 or 30 minutes at the beginning of the night or in the midst of the night. If that occurs at least 3 nights a week for more than 3 months, we would say that somebody's experiencing chronic insomnia. Generally, in sleep, sensation and pain are not recognized. Again, the thalamus is going to cut off that signal, that relay from the body to the cortex, the surface of the brain, so that we don't have consciousness, we don't have awareness of these sensations. That being said, there can still be some correlates seen on an EEG when we measure brainwave activity. If we cause someone to have pain in sleep, there are changes that are noted within EEG. So I would say it's not a complete mute. There are certainly possibilities of signals getting through to the cortex. And certainly as we rouse somebody, attempt to wake somebody, obviously we break through that lack of perception. It's interesting, I've seen patients who have sleepwalking. A woman I remember from my training at Stanford who lived in Idaho and actually ended up sleepwalking out to a river near her house. This was in the winter, it was cold, but she had no perception of the coldness. She walked to the river and woke up in the river, in the very cold water sometime later. So I was able to really not perceive temperature, not perceive discomfort and pain for a prolonged period to be able to get out to the water. Poor sleep due to inadequate total sleep time, so not enough hours. Most adults need 7 to 9 hours. Poor sleep quality, so sleep that's fragmented, disturbed for various reasons. And again, sleep disorders, primarily sleep apnea, but other disorders including restless legs and periodic limb movements of sleep may increase experience of pain. Many people with a chronic pain disorder have an associated sleep disorder. So half of people with a chronic pain condition have insomnia symptoms, insomnia complaints, and certainly other conditions like fibromyalgia have high rates of other sleep disorders, including sleep apnea. So a little bit more about neuropathy and sleep. So peripheral neuropathy may be associated with a condition called restless legs syndrome, which I'm going to talk about at length here, and an associated finding which we call periodic limb movements of sleep. The latter are movements, flexion movements that can fragment sleep. So it's a contraction involving the lower extremity that can actually cause awakenings and cause cortisol release and other consequences. Untreated sleep apnea, importantly, can contribute to the risk for prediabetes, diabetes, insulin resistance, and it independently also worsens restless leg symptoms. So that may be related to sleep fragmentation and the effects, or the effects of oxygen deprivation and systemic inflammation, how those things affect our likelihood of developing RLS symptoms. There are many treatments that will target restless leg syndrome or periodic limb movements of sleep that would also potentially cause or provide some relief from neuropathic pain. So there's overlap here. And because so many people with peripheral neuropathy also have restless legs, I think it's an important topic for us to explore. So a little bit of the historical context. So restless legs was really first described by Sir Thomas Willis in 1672, and he described patients he was seeing that had a restlessness and movements affecting their limbs that was found to be quite disruptive to their sleep, and described it as if they were in a place of the greatest torture. So these folks were really extremely affected in a negative way by these symptoms. He is a man who coined the term neurology. I'm a neurologist by training. He first identified and numbered the 12 cranial nerves. He described the blood supply to the brain, which is named after him. It's called the Circle of Willis. So somebody who's very important in the development of neurology as a field. On the right-hand side here, we have a Swedish neurologist, Carl Axel Ekbom, who was a man in 1945 who, as part of his doctoral thesis, described the term restless legs. Ekbom's syndrome is another condition named after him that actually refers to a delusional parasitosis. So something's crawling under my skin, something's in my skin, suggesting he may have had a really persistent interest in these funny sensations that happen in the body. So these two men are largely credited with identifying and developing the early clinical management of restless leg syndrome. And so sometimes that condition is called Willis-Ekbom disorder in honor of these two men. Now, importantly with restless legs, there can be some misnomers or confusing eponyms. So restless leg syndrome is a descriptor that fails to recognize that from 21 to 57% of people actually complain of arm symptoms instead. And so it may not just be legs, it may not be legs at all. And that's where that new descriptor, Willis-Ekbom disease, is meant to recognize some of the variability of the presentations and the impacts of the disorder. You can see this little dial here spinning. It describes some of the symptoms associated with restless legs. We'll go through those in just a moment here. It is both a sensory and a motor disorder, so affecting both sensation and potentially movements. and is characterized by a nearly irresistible urge to move the limbs, often accompanied by a very uncomfortable, disagreeable sensation. So this urge acronym is useful to identify the key features of what is really a clinical diagnosis. We don't require any testing to say that somebody has restless leg syndrome. We just identify these symptoms. If somebody agrees that they have these symptoms, then they are diagnosed with the condition. So first is an urge to move the limbs, usually accompanied by an uncomfortable or unpleasant sensation. It will occur at rest or in periods of inactivity. So often lying down or sitting will precipitate or worsen the symptoms. And that may be towards the end of the day when somebody's resting, reading, watching TV at the end of the day. It can also occur in other sedentary environments, sitting on an airplane, being in the car, sitting at a performance, symphony or something. With this, there's the fact that the person will get up or move to provide a partial or total relief of the symptoms. And as long as they're walking around, rubbing on their legs, stretching, moving, those symptoms will abate. And these symptoms, the last part here, E, come on in the evening or at night. So there's a clear circadian pattern to these symptoms. Now, as things evolve, the circadian pattern may not be as evident. Sometimes symptoms will come earlier in the day or be nearly constant. But these are the key variables. So an uncomfortable feeling, often in the legs, not always, associated with an urge to move that is relieved by movement and occurs again in the evening and in activity typically. So sometimes patients will not read the book. They don't know that they're supposed to have those specific descriptors. So they might come in with other complaints. And so you might recognize some of these yourself. But rather than saying I have restlessness in my legs, they might complain of tingling, electrical feelings, squeezing, pain, twitchiness. They might say they have a need to stretch or have that urge to move, that they want to move, or that their legs want to move. And children might use age-appropriate words. They might say they have bugs crawling on their skin. It's not just the legs, as we've talked about, arms and legs both, but also the genitals can be affected. The chest can be involved. So really any part of the body can come with these symptoms. The urge to move may occur without any specific discomfort. So again, somebody might say, I have to move, but not recognize any specific discomfort with that. When very severe, as I noted, the movement may not actually provide the person relief. And importantly, some medications that we use, including medications called dopamine agonists, which I'll talk about here in a moment, may actually over time make the symptoms worse so that they're more severe, they occur earlier in the day, they affect other parts of the body, and so we mask that prior circadian pattern. So again, clinical diagnosis of this condition, no objective test is required. It's important that the person assessing you is ruling out other things that might sound a little like restless legs. And so leg cramps, which is a painful contraction of the leg, positional discomfort if I'm lying in a certain position, my legs bother me, so I have to roll over. Myalgia, muscle pains, venous stasis, edema affecting the legs. There are conditions of movements of the legs that are like tapping or other movements that can occur as like a soothing mechanism as somebody is falling asleep. Certainly arthritic pain can be important. And then there's this overlapping condition called periodic limb movements of sleep that we'll talk about here in a moment. As we dial into this diagnosis, asking these specific questions can get us the right answers. So 40% of normal people have an urge to move the legs at rest. That's a very common acknowledgement. Improvement with movement and the idea that this is worsened in the evening or at night will capture 70% of those who actually have restless leg syndrome. And if we rule out these mimics, we set aside leg cramps, positional discomfort, some of these other things that might be confused for restless legs, then we get up to a 94% accuracy in the diagnosis. All without a test. Again, no testing is required. This is just an interview process identifying symptoms, and it helps us to nail the diagnosis. It's fairly common. This condition affects up to 10% of European and Northern Americans. 2 to 3% will have consequences that are disrupting their life and seek attention. Children can also be affected. 2 to 4% of children have restless leg symptoms. The prevalence does increase and tends to plateau after about age 60 to 70. Studies vary, but 5%, maybe up to half of people with peripheral neuropathy have restless leg symptoms. It can be familial, run in families, and often folks would have onset at a younger age. The progression can be slow or stable. People can have remissions. It can worsen in certain contexts. Late onset disease, folks who develop this kind of in the context usually of other disorders may have a more rapid progression and may have a more severe presentation. The causes of this. So we don't fully understand what causes restless leg symptoms. There are likely genetic predisposing factors. It seems to relate to iron deficiency within the brain, also improper regulation of dopamine within the central nervous system as well. Again, it may be idiopathic, meaning we don't know the cause, or run in families. It can be secondary to other conditions, which we'll talk about here in a moment. There are some identified genes that are connected to restless leg symptoms, and those who have a first-degree relative, perhaps a parent or sibling, child, that have that condition will have a greater risk of having it themselves. So iron's important. Iron affects dopamine production and synapse density, the synthesis of myelin, which is a coating of our nerves, and also energy production within the brain. There's a lot of different ways to study this, but they support the idea that iron deficiency has a role. So whether we do an autopsy looking at iron, or do MRI studies, or do a sonogram of the brain, or even do CSF analysis looking at iron, they tend to verify that there's a role for iron deficiency in the symptoms. Generally, when we measure iron, we measure something called the serum ferritin level, and if low, this is indicating less than 50, that would suggest a deficiency. I would say that that's kind of a moving bar. Sometimes we say less than 70, sometimes less than 75, sometimes less than 100. So if you're falling anywhere within that range, I would say less than 100, and you're symptomatic, iron treatment, iron replacement may be important. There's also dysfunction of dopamine, so this is another potential cause of these symptoms, but improper regulation of dopamine appears to be important and is again supported by functional MRI scans, PET scans, autopsy studies, and other things. So those are all very important kind of studies that would verify again that we've got dopamine contributing. And then it helps to explain why dopamine agonist medications can improve these symptoms, that it is addressing one of the root causes of the symptoms. What else can be associated or a potential cause of having restless leg syndrome? So we talked about the iron deficiency, but chronic renal failure, kidney failure increases the risk. Being pregnant, having prolonged immobility. Certain medications can trigger this. So diphenhydramine is a generic of Benadryl and is found in a lot of different sleep aids like Tylenol PM, Advil PM, and others. Antidepressants generally will worsen restless leg symptoms with the exception of bupropion or Wellbutrin. There are other centrally active dopamine receptor antagonists. So these are often medicines that are used to treat schizophrenia, schizoaffective disorder. Those can potentially cause restless leg symptoms as well. And then it's associated with other mood disorders and ADHD, diabetes, multiple sclerosis, Parkinson's, rheumatic disease, and also varicose veins. So many of these conditions, again, overlap in a way that somebody diagnosed with Parkinson's may also experience this restless leg syndrome. And again, dopamine is probably an important contributor to those two findings. So what are the consequences when someone has restless legs? It can be quite severe and quite disruptive. Often people will complain of insomnia, so 60 to 90% are affected in that way. They may complain of increased disruption to their sleep, awakenings, arousals, poor quality to their sleep. The movements associated with restless legs may also shake the bed and bother their bed partner. There can be, of course, sleepiness and fatigue during the day, and also worsened control of pain. And it does have an effect on quality of life. So studies have shown that when people have untreated severe restless legs, that the burden is as bad or worse than people who have advanced congestive heart failure or depression Parkinson's or stroke, that the condition has a similar impact on quality of life. And children may experience or complain of growing pains or have signs or symptoms of ADD or ADHD during the daytime. Now, I keep mentioning this associated condition, periodic limb movements of sleep. I want to take a moment just to comment on that. So restless leg symptoms would be what someone complains of when they're awake. Periodic limb movements of sleep occur as somebody is asleep and often would be measured as part of an in-center sleep study. So home sleep studies will often not measure anything related to the legs. They're often breathing assessments, sleep apnea assessments. In-center testing, when we bring someone into a sleep center, we measure EEG brainwaves, we measure heart rhythm, EKG, breathing patterns, but also leg movements and sometimes even arm movements. So we can pick up on limb movements that might be causing awakenings or disturbances to sleep quality. These movements typically occur in the first third of the night. Often there's an extension at the toe, which means lifting up at the toe, great toe, a flexion or pulling back at the ankle and knee, and sometimes even at the hip. With that movement, again, there can be a disturbance that leads to an awakening, fragmenting sleep, undermining sleep, and it may bother bed partners. We consider this to be significant when there are more than 15 movements per hour for adults, more than 5 movements per hour for children. And again, it can lead to disruptions of sleep. And there are some good studies that show there are cardiovascular consequences to this as well, that somebody can be at increased risk for high blood pressure and cardiac disease when periodic limb movements of sleep are untreated. We generally don't treat them in isolation, especially if they're under those thresholds I just noted. But they're very commonly associated with restless leg syndrome. Somebody may experience restless legs when they're awake, and then once they fall asleep, it's estimated about 70% of those people continue to have leg symptoms, movements that disturb their sleep or their partner's sleep. So when do we treat this condition? So we often will consider how often these symptoms are occurring and the severity of the symptoms. Many will put off therapy until they're bothered enough or the bed partner's bothered enough to be sufficiently impacted. Usually when people are coming to me as a sleep specialist or coming to see a neurologist or coming to see a primary care doctor, they're probably interested in treatment. If they're bringing it up, they're ready to have that conversation, that discussion. And when people come to see me as a sleep specialist, they've often failed many of the initial treatments or they've been on those treatments and over time they're not working any longer. So we often need to take a step back, reassess, make sure we're not missing other contributions to these symptoms, and often move them to specific therapy. So how do we treat restless leg syndrome? And again, a condition that has important consequences to sleep and would affect pain as well. So the first thing that I often do after I have evaluated somebody and identified that they have the condition and that they're eager to move to a treatment is I would check their serum ferritin level. There's often a complete blood count that's checked if that's not been evaluated recently as well. And again, there's different cutoffs here. This one's 75. We've used 70. It changes, honestly, it changes yearly, it seems, but you might use 75 or even 100 as a cutoff of normal. And that can be within the normal range for a ferritin level. So depending on the lab's values, they might say, well, it's normal. But again, if it's less than 75 and you're symptomatic with restless leg symptoms, that would be a level at which we would want you to take iron. So typically we use an over-the-counter iron supplement, often ferrous gluconate. It may have up to 65 milligrams of elemental iron. It's best to take that half a tablet or full tablet daily, and then as needed, move up to 3 times a day. It's often taken with vitamin C, so 100 or 200 milligrams of vitamin C. Vitamin C is a cofactor to absorb the iron, so it helps move it into our bloodstream. And it's better to take this actually on an empty stomach, so 2 hours before or after a meal. That helps absorption. It helps the iron to get into our system. If you take it with food, you may not absorb as much of that supplement. Now, the side effects to iron supplementation often include upset stomach or constipation, so we have to be careful about that and sometimes take stool softeners or things to counteract that. And typically, if someone's taking an oral iron supplement, we may recheck their levels about 6 months into repletion just to make sure that things are moving in the right direction, the numbers are getting better, and often there'll be symptomatic relief to guide us as well. But we also want to make sure they don't get into an iron overloaded state, which is rare, often part of hemochromatosis, but something that we wouldn't want to have happen. So that's a checkpoint that we usually would review the iron at 6 months. Now, if somebody's iron levels are not coming up with oral iron, or they cannot tolerate oral iron, then we think about IV iron infusions. And this, through my institution, often managed through hematology. It can be done as an outpatient infusion. And again, there may be several doses. Sometimes we infuse somebody, the level comes up some, and then we need to monitor and reinfuse. The frequency of that infusion may vary based on your absorption of iron through your diet and some other variables, but it is often repeated over time. Side effects to these infusions are fairly rare and transient in nature. Now, we can also use medications that enhance GABA to treat restless leg symptoms. And these medications often get used to treat a neuropathic pain more generally. And so you're probably familiar with some of these agents. GABA is shown here is something that calms down the nervous system. It slows the nervous system. It can deepen sleep and relieve pain. It also can slow brainwave activity and treat seizures as well. Most options include, for folks, gabapentin or Neurontin, and that might be used for occasional symptoms, breakthrough symptoms. So let's say you're bothered with restless leg symptoms when you're sitting on an airplane. You might take gabapentin for that flight to help calm down those symptoms. We can use Horizant, which is a long-acting gabapentin formulation with a slightly altered absorption that helps it to have a more sustained effect. And then there's also pregabalin or Lyrica, which can be useful or used as well. And these agents, pregabalin, Lyrica, Horizant, and gabapentin and Neurontin, are now really seen as first line of treatment. So the American Academy of Sleep Medicine just this week released new guidelines recommending that we use these agents as first line for therapy for restless legs. And that's a change from some of the medications that have been used in the past. The most common side effects to GABA medications would be dizziness, sleepiness, sedation, morning hangover effect potentially, and weight gain. So we sometimes have to monitor weight or the other symptoms to make sure people are not negatively affected by the medication. A little bit more about Horizant. So again, used for moderate to severe restless legs as well as for postherpetic neuralgia. It is a prodrug of gabapentin and has a novel absorption. It's usually dosed with food in the evening. It's well tolerated by most people. Folks with restless legs tend to respond well to the medication. Side effects are generally in the early weeks or month of use, and about 10% of people withdraw from treatment due to side effects. We're careful about effects on behavior, mood, suicidal thought. If that comes on, then of course we need to stop the medication. Higher doses were not more effective and just made side effects worse. Now, often when people are diagnosed with restless legs, at least historically, they are started on dopamine agonists, and especially among primary care providers, this may still be the first treatment that is reached for, even though, again, the American Academy of Sleep Medicine just this week now discourages the use of dopamine agonists for therapy. So these include pramipexole, ropinirole, which is Mirapex and Requip, as well as a patch called Nupro. Mirapex has a 7% annual rate of augmentation, which is a worsening of symptoms, again, more severe early in the day, other parts of the body. And so that's one reason why we're moving away from using these medications as first-line agents for restless legs. Response is often seen with treatment, but because of this augmentation, it has really limited its role in long-term use. Now, if you are currently taking this medication, I would certainly advise continuing it, but have a conversation with the doctor that's prescribing it to see if there may be some alternatives for you. Compulsive behaviors are rarely seen as a side effect. These can be compulsive things like shopping, online shopping, gambling. And so when people have this experience of compulsive behaviors, we have to stop the medication. There's another dopamine effective medication called levodopa, and again, because of the risk for augmentation, it is not recommended as a treatment for restless leg syndrome. The Nupro patch is a newer treatment. It's for moderate to severe restless legs and Parkinson's. We start a low dose and increase. It's a daily patch, and it has some side effects, including rash associated with it. Skin reactions are more common in early use, with maybe 20% of people stopping therapy because of the rash. And again, a high risk for augmentation. About 13% of people had augmentation. Because of the adverse effects or the lack of efficacy, more than half of people in this 5-year trial on the Neupro patch stopped therapy. So it does not seem to be an effective treatment for majority of people over a longer period of time. And again, augmentation is a big part of why this fails over time for folks. Benzodiazepine medications, and there are a number listed here on the right, are not considered first-line treatment due to the risk for abuse, dependence, and overdose. But when someone has very intractable, severe symptoms, we may consider them as an option. They can also help with comorbid insomnia and anxiety. And we usually would consider agents with longer half-lives. So clonazepam and diazepam are two that get used. And because of their long half-lives, that can help with restless leg symptoms throughout the 24 hours. We often turn to narcotic medications or opioid medications in very severe restless legs, very intractable restless legs when we're unable to provide relief in other ways. It's important that we consider these very carefully and limit them. Sorry that this image hasn't popped up yet, but methadone is often what we would consider using. Methadone at low doses can help intractable restless legs. Most patients respond well and have a sustained benefit to the use of that low dose. If somebody is needing more and more of the medication, that tends to point us away from the use of that medication. The rate of discontinuation with methadone is very low, and one study suggested that up to 10 years, people continue to use the methadone with benefit. There's not augmentation with methadone. Unfortunately, there is some stigma. Methadone is associated with people who have opioid use disorders, so methadone clinics. It may not be available in all states as easily, and that's important to consider as well. Some state laws actually may restrict access to certain dispensing clinics, or in certain cases it may not be available at all. There are alternative treatments, and I'm going to talk specifically about ways to improve pain at night for those who just have peripheral neuropathy and not restless legs as well. But this is a treatment for restless legs. So we consider this in pregnancy, or when there's other medications that someone's taking. We need to be careful with introducing another medication. It's important to avoid triggers, including caffeine and certain situations that might bring out symptoms. Again, stretching may be helpful. Sitting on a plane doing the crossword puzzle in the magazine on a plane can be helpful. And there's also pads that can be used that vibrate and again provide a stimulus that may relieve pain or may relieve restless leg symptoms. So the Relaxis pad is one of those examples. It's FDA approved. You put the pad under where you're having discomfort, and you can set the amount of vibration of the pad to a level that feels comfortable. It does vibrate for 35 minutes and then gradually ramps down before it shuts off, so that it's meant to be used as you're transitioning to sleep, and then as you fall asleep, it slowly turns itself down. Side effects are pretty minimal, sometimes cramping or tingling, soreness, pain, unusually motion sickness. It does require prescription, and it is expensive, which I think makes it less desirable. I was looking for the pricing recently. I don't know if this is actually a current price, but this is what I had found previously when I looked for it. Now, there are lots of ways we can potentially relieve pain from home. So last minute here or so before we switch to questions, I just want to point these things out. So a warmer bedroom environment rather than a cool, cold environment. Having good sleep habits, good sleep hygiene, using socks that will buffer our feet and lower legs from the sheets and covers. Maybe taking an evening dose of pain medication, sometimes topical pain relief, using capsaicin or lidocaine topicals. And there's also a role for something called CBTI. I'm an expert in CBTI. I've written a book on this called Sleep Through Insomnia. I put together an online course called Insomnia Solved, which you can find and review. But this is a 6-week program teaching you how to normalize sleep, how to optimize your sleep drive, your circadian rhythm, ways to deal with a busy mind at night using distraction techniques, breathing, muscle relaxation, guided imagery. And there are lots of studies that support the use of this, and I think it helps to reduce insomnia, it helps to reduce pain, and it generally will benefit someone's sleep. So ideally, therapy should be addressing bothersome symptoms with minimal side effects. We start the therapy when someone is affected. Medications that enhance GABA are now considered first-line therapy. We can use occasional medications with situational exacerbations, and benzodiazepines and opioids are often as a last resort for restless leg syndrome, but they are quite effective and really can completely resolve a condition if somebody's in need. I would consider seeing a specialist when you need this support. So if the primary care provider is unable to get your symptoms under control, reaching out to a neurologist, reaching out to a sleep specialist, I think for optimized care is important. So I have my details here for folks who want to reach out to me and contact me, but I think we now have time for questions.
Yeah. Hi there. Thanks so much. Well, that was a very thorough presentation. We do have some questions that have been coming in, so we'll take the next 15 minutes or so to kind of touch on those. So curious what you think the best natural remedies are available for folks that are having sleep problems and also suffer from peripheral neuropathy.
Yeah, so the over-the-counter things that we have access to tend to fall into several broad categories. Again, I would be careful about over-the-counter sleep aids that contain diphenhydramine and doxylamine. So these are going to be Benadryl and the PM drugs, Tylenol PM, Advil PM, and then doxylamine, which is a related medication, which would be in like Unisom, Costco sleep aid, etc. Be careful about those medications because those could potentially worsen restless leg symptoms for you. So I wouldn't want to lean into those too much. Melatonin is often used as a sleep aid. It's fairly weak for most people, but I think it is safe to try. You would want to use a consistent supplier because there's a lot of variability in what's actually in the pill, and so you don't want to switch between brands because you might be getting totally different doses. Typically, you want to use a low dose of melatonin, so I would stick to under 5 milligrams. You don't want to be taking 10, 20 and more because you'll flood your system in a way that will actually work against you. Most people take 1 milligram or 3 milligrams kind of close to bedtime. If you have a circadian delay where you're a night owl, you actually want to take it 2 or 3 hours before you're intending to go to sleep. But valerian root can be helpful for insomnia, anxiety. I would not use kava kava. There's liver toxicity with kava kava, and that's actually a banned substance in Europe. Some people will use serotonin, tryptophan. These are ultimately converted into melatonin, so that's how that's potentially having an effect. But there are some options, chamomile teas and other things, and sometimes it's just trying it and seeing if there's a benefit. I think most of these are fairly low risk. If you find it's helpful, great, keep using it. If you're struggling, you try these things and you're still struggling, I again would lean into CBTI as the best way to resolve insomnia and may help that transition to sleep.
And do you typically encourage your patients to give it at least, 3 to 4 weeks after starting some type of new treatment plan just to see is it working or not, and not break before that time frame?
Yeah, I think that's a reasonable time frame. And again, your body's getting used to the medication, you're adjusting the medication, you may be even increasing dosing potentially. And if you're taking something that's prescribed, obviously be in touch with your provider as you make changes. But yeah, you want to give it time to work. Don't step away from it too quickly, or you may find that you're running out of options more quickly.
So some of our folks have complained about kind of like poor circulation, for fear of better words, especially in their lower legs and feet. They get very cold, very uncomfortable. Curious if that has anything related to, neuropathy, specifically when they're sleeping. If you could speak a little bit more to that.
Yeah, I think that's a common complaint that people notice that or feel that, and it can come back to root causes potentially. And you might say, well, what can I do about that? Again, the idea of kind of wearing a soft sock, perhaps having a heating pad on your lower extremes, keeping the room generally more warm. I think all of those can be helpful. We humans tend to find it more comfortable to sleep in a cool room at night, but again, if you've got some neuropathy causing discomfort in your lower extremities where your circulation is not adequate, you can try some stretching, some exercise before going to bed. Again, you might want to put on socks or have a heating pad. for comfort, and we actually regulate our body temperature through our feet. And so often people, when they get overheated, will kick their legs out from under the covers trying to cool themselves off. So but yeah, if you can kind of think about your options and sort of target something that is providing you some comfort, I think that can be helpful. And ultimately it may come back to addressing root causes. If you've got a vascular issue, something that's contributing to the poor circulation, you may need to address that.
No, that's fascinating. And you hadn't really touched much on cannabis. Curious if you have any comments on that.
So it's not well studied at the federal level. We're restricted in studying it, so it's a lot of anecdotal evidence. Generally, it is something that can be helpful for initiating sleep, for calming us, for reducing anxiety. And it's CBD that's more cannabidiol, more important than THC, that has an effect on sleep. I will tell you that where I live in Seattle, I mean, it's legal to access it and patients do come in using it. They will tell me that it can be helpful, but some will find that over time it doesn't seem to be working as well anymore. The physiology of it seems to be that it suppresses REM sleep, and that can be helpful for folks who may have disturbed REM sleep, especially if they have sleep apnea. That suppressing REM sleep, that might actually improve their sleep quality. So there may be a benefit there. And as with any other supplements, over-the-counter things, I mean, if you try it and there's a benefit, people will continue. If there's no benefit, of course, you set it aside.
Right. Yeah, agreed. So curious, have you seen more patients with peripheral neuropathy having leg spasms? Do you think that that is kind of like a mutually exclusive thing, or do other people that don't have neuropathy also have or experience as many frequent nocturnal leg spasms?
Yeah, and I think, so there's spasms, which we could use the word to describe limb movements of sleep, or we could use it to describe leg cramps. And again, there's a lot of overlap with these things. And I would say perhaps folks with peripheral neuropathy are more likely to have periodic limb movements of sleep, are more likely to experience leg cramps. Leg cramps are hard to get control of often. People will take magnesium. There's supplements that can be used over the counter, sort of homeopathic supplements. Sometimes we need to figure out why the cramps are happening and again, get to a root cause. For some folks, that means identifying and treating sleep apnea, that oxygen deprivation is causing those tissues to cramp in sleep. They wake up in severe pain from a leg cramp. There can be other contributing factors too, but yeah, there is a lot of overlap between peripheral neuropathy and either PLMs or cramps, and sometimes it can be hard to get them to settle down.
And Dr. Peters, have you found any objective studies that have investigated the efficacy of compression socks or other types of stockings to diminish some of these symptoms when people are feeling them in their lower extremities?
There is some evidence, and not large studies. I would say generally sleep studies tend to be fairly small, but there are studies that suggest compression stockings or other wraps can help the feet, and even restless leg symptoms. There's a device called Restific that is basically a wrap of the foot with some Velcro that kind of binds the foot a little bit. That seems to provide some relief. And so again, why? Don't fully understand perhaps. Again, the idea of contact or interacting with the environment, perhaps that has a signal to the brain that can override some of these other disagreeable symptoms. But yeah, there is some evidence that those things can be helpful. And again, easy to try, fairly inexpensive. If you try and say, yeah, things are better, great. And again, if you try them and say, well, I didn't do anything, put it aside, try something different.
Yeah, right. Have you, I'm kind of bouncing around, so I apologize, but have you heard about the Inspire system? And do you have any thoughts on that?
So the Inspire, for those who don't know, this is an implant. It's a hypoglossal nerve stimulator for obstructive sleep apnea, for moderate to severe sleep apnea. If someone does not tolerate CPAP, then we can consider this option. We have been doing it here at Virginia Mason Franciscan Health here in Seattle for about 18 months. We were not early adopters because the initial implants were not MRI compatible. And as a neurologist, I know the importance of MRIs, and I didn't want to take that away from people's future access. So we waited, and the newer ones are now MRI compatible. And so we've been doing it for about 18 months. I think we have close to 100 patients who've gone through the procedure or going through the process to get the implant. seems to be very helpful. Some people have persistent snoring or sleep apnea, and we have to fine tune the settings of the device. But what it's doing is it detects your breathing pattern and then stimulates the hypoglossal nerve in sync with breathing. So it contracts the tongue muscle, opens up the airway in sync with breathing. So you turn it on, there's a period of time that elapses, it starts activating, and in the morning you pause it. But it can help to reduce snoring and sleep apnea for folks who have that condition.
That's very interesting. So I'm going to actually, I'm going to ask one last question. I know we're running pretty short on time. I want to be respectful of your time as well as our patients. So a lot of other questions I will try my best at answering at a later time for those who are interested in reaching back out to us. But the last question is, do you think specifically that neuropathy is interfering with some of the stages of our sleep, or is that mainly due to age and our sleep cycles are being disrupted regardless? Do you think, I guess we're trying to find out how much greater of an impact neuropathy plays in the sleep cycle. Curious if you could speak to that before we close.
Yeah, it's a great question. I would say personally, and I think more broadly, we don't know. That's something that is not fully understood. If we take a step back and think about it in a theoretical sense, it would be hard to isolate somebody with peripheral neuropathy who's not experiencing other conditions that would disturb sleep or have age-associated risks or other risks. So it may be hard to study. It may be something that's difficult to study. I would say generally that peripheral neuropathy is going to be disruptive to sleep, and whether those signals are getting through the thalamus, getting to the cortex and disturbing sleep in that way, or that we just naturally wake, we move at night, we're ending a sleep cycle, we wake, like there's just normal wakefulness, but as we come to consciousness, then we have these symptoms that come to our attention, and then there's a secondary disruption. So I think it's difficult to tease apart. I think it would be a difficult thing to study in isolation, but it makes sense to me that people with peripheral neuropathy, again, because of these other things we've talked about, are going to have more symptoms at night, are going to have more disruptions.
Well, this has been fantastic, Dr. Peters. Thank you so much. I have a feeling that a lot of people that are either watching live right now or going to be watching later will have a lot of questions for their specialist or their primary care physician about, you know, how they can maybe consider taking some of these medications or trying different things to try to kind of help stem the sleep cycle a little bit better. So, so Dr. Peters, again, thank you so much for your time. We so appreciate it. Thank you to everyone watching today. We hope you enjoyed the program. We obviously appreciate that you have been tuning in to us for all of your educational needs. So please take the survey at the end of this program. We would love to hear how we did, opportunities for improvement, things that you really loved, things that you'd love to see, and obviously our contact information is here too. So feel free to reach out to us. We'd be happy to try to continue to assist you. Obviously, lots of questions came in, so I apologize we weren't able to get to all of them, but I thank you so much, and I hope that the information that was disseminated today was extremely helpful, at least it was to me. So again, thank you so much on behalf of the Foundation for Peripheral Neuropathy, and have a great day, everyone. Bye-bye.